What's up everyone, it's Jessica and welcome to CritIC. In my videos on acute kidney injury, you've learned the definition, how to interpret serum creatinine, and the workup to the respective causes of acute kidney injury, pre-renal, renal, and post-renal. In this video, I'll walk you through how to go about the entire workup when encountering such a patient. Let's go. You're consulted by the orthopedic surgeon to take a look at her patient she's admitted yesterday. 64-year-old Mr. Cohen is supposed to get knee replacement surgery, and the surgeon performed labs today, which showed a creatinine of 120 micromoles per liter. Previous value was 80 only 1 week ago. So, acute kidney injury. Let's go through this. In your mind, you already go through the causes. Pre-renal, you want to get a sense of his volume status. So, fluid loss like vomiting and diarrhea or less fluid intake. And drugs like ACE inhibitors, NSAIDs, and diuretics. Let's calculate the fractional excretion of sodium. Renal, ATN, low flow states, drugs, deposits. And TIN, UTI and drugs. And don't forget glomerulonephritis, but we might see that in the urinalysis. Right, get a urinalysis. Post-renal, could he have an obstruction? Consider an ultrasound. History and exam tells you that Mr. Cohen has had coronary bypass surgery 7 years ago. He doesn't have heart failure. He's an active man that takes his medication faithfully. His list of meds is short: metoprolol, lisinopril, and an aspirin. He also started taking Advil from the store for the last 2 weeks as his knee keeps hurting. 2 days prior to admission, he'd eaten a bad sandwich which led to severe diarrhea. The next day, 1 day before admission, he felt a whole lot better, so he didn't think it was important to tell the surgeon. He stopped eating and drinking at midnight due to surgery the next day, and he didn't get an IV drip. He doesn't have a fever, no pain at urination, no pain in his abdomen, sides or back, and his urine looked normal. He didn't notice that he peed either more or less often. This sounds pretty pre-renal already. Diarrhea combined with an NSAID and an ACE inhibitor. The labs you need are the following. Serum creatinine and sodium for the fractional excretion of sodium. You don't really need urea since he's not on diuretics. You'll need all the other electrolytes, especially potassium and phosphate, to check for possible complications. If renal clearance decreases, you could get serious hyperkalemia. You also need a urine sample for the urinalysis. You'll want to know if there's red and white blood cells, nitrite, protein, etc. And you need a sample on urine creatinine and sodium for the fractional excretion. Labs are in. Okay, so the fractional excretion of sodium is less than 1%, which indicates pre-renal kidney injury. This also fits the history and exam. You go through the other causes in your mind. ATN isn't likely as the duration of the dehydration wasn't that long. He doesn't have a UTI, and the urinalysis doesn't fit either a glomerulonephritis or a TIN. Post-renal is always a possibility, and it isn't excluded yet. But you have a sufficient explanation for now, so there's no need for an ultrasound at this moment. You advise an IV drip, cessation of the lisinopril, monitoring urine production with a catheter, and checking serum creatinine and electrolytes the next day. If renal function doesn't improve within 48 hours, you repeat your labs and advise an ultrasound. And that's how I go about acute kidney injury. I hope these videos were helpful to you in your daily practice. Please let me know in the comments section. Share this video if you liked it. Thanks.